started. We're really happy to welcome Professor Yin Paradies with us today. And I might actually get Olivia to do the, can you pin Yin to the thing? Thank you. Look, I'd like to start by welcoming everyone who's online and who's in the room. And acknowledge that many of us today are meeting on Larrakia land. We have other people joining from Aboriginal land in other parts of Australia. And we really want to pay our respects to elders past and present, and also to emerging leaders, and acknowledge Aboriginal people who are joining us in the room and online today. A quick introduction to me, for anyone that doesn't know me, I'm Professor Anna Ralph. I lead the Communicate Study Partnership, and part of the work that we do is try to foster a community of practice around cultural safety in healthcare. And so we offer these seminars on a monthly basis, as well as doing other activities looking to sort of promote cultural safety in healthcare. So this topic that Professor Paradies is presenting on today about decolonising cultural safety, I'm really looking forward to, and I imagine I'm probably going to have a fair bit to learn today. By way of introduction to Yin, he's a Wakaya man who's a leading scholar and recognised international expert on racism. His research focuses on the health, social and economic impacts of racism, as well as anti-racism theory, policy and practice across a number of settings: workplaces, education, healthcare, and so on. He's contributed significantly to Indigenous knowledges and has a very strong academic track record with lots of outputs, and he's often called upon to speak at conferences and meetings. So we're really happy that he was able to offer his time to us today. So Yin's going to present for us, and then there'll be the opportunity for questions at the end. We're recording the session, and over to you, Yin. Thank you so much.
Thanks, Anna. Thanks for inviting me along to this series. So I've got a bunch of slides, and they'll probably only take about half an hour to get through, and then we should have plenty of time for discussion. But of course, if you'd like to discuss as we go, that's also welcome. Probably won't be able to see any hands up, but in the chat is a good option for questions as we go, and I'll try and keep an eye on that. So, decolonising cultural safety. Yeah, let's talk about that. So the first thing to talk about is why focus on cultural safety at all. There's a few good reasons for that. We have the whole health inequalities issue that's been with us for the entirety of colonisation. Increasing focus on unconscious or implicit bias, stereotyping, medical uncertainty, and more explicit forms of racism in healthcare settings. So all of this really is about providing high quality healthcare, and cultural safety is pretty much synonymous with that idea: equitable, high quality healthcare for Indigenous peoples. And all of that will contribute to closing the gap, which of course is a very big endeavour and policy platform these days, and has been for a little while. So that's pretty obvious, I'd say, to most of us who've come here. What is cultural safety? Well, there's a few definitions around. Here's one: environment that is spiritually, socially, and emotionally safe, as well as physically safe for people, where there is no assault, challenge, or denial of identity. Identity has been an important part of the definition since it was originated, I would say. It's interesting to think about that focus more if we want to talk about it. Who people are, what they need. It's about shared respect, shared meaning, shared knowledge, and experience of learning together. Co-emergent, I would say. Lots of togetherness in that definition. Another one, much more recent definition, cultural safety is about being welcomed, respected, supported, and empowered. Welcomed, respected, supported, and empowered. By the way, we'll make these slides available after the talk, so no need to furiously write notes. The references are in the notes of the slides, so you can find those as well. So cultural safety is determined by Indigenous peoples, families, communities. That's a really important aspect of the definition that differentiates it from other related concepts. We'll talk about those soon. Culturally safe practice is the ongoing critical reflection of health practitioner knowledge, skills, and attitudes, practicing behaviours, power differentials in delivering safe, accessible, and responsive healthcare free of racism. This is a pretty recent APRA definition. It's got a lot going on there as well that we could unpack. The focus on racism explicitly is quite interesting, and the many aspects of health practitioner activities, also interesting. So Alana Curtis from Aotearoa has also done some important work on cultural safety. This definition, and others, of course, in her colleagues, requires healthcare professionals and their associated healthcare organisations to examine themselves and the potential impact of their own culture on clinical interactions and healthcare service delivery. Reflexivity is a big part of cultural safety. Requires individual healthcare professionals and healthcare organisations to acknowledge and address their own biases, attitudes, assumptions, stereotypes, prejudices, structures, and characteristics that may affect the quality of care. So lots of self-reflection, lots of examination as part of that. And that's where this idea of critical consciousness emerges as an aspect of cultural safety. Self-reflection, self-awareness, and accountability. Reducing bias, achieving equity, and so on. You can see some themes emerging here on how people characterize cultural safety. So that particular definition was developed considering determinants of health inequalities, the importance of cultural safety being determined by patients themselves, the need for more work in this space, and an organisational responsibility for that. That's beyond individual practitioners. We could look at the journey of cultural safety in Australia from the 1980s, the National Aboriginal Health Strategy, work by RACGP, the cultural safety definitions from the founder of cultural safety in Aotearoa, and so on. More work by the Committee of Deans, CDAMS, the National Aboriginal and Torres Strait Islander Public Health Curriculum Framework in 2008, work by Greg Phillips, and accreditation, the movement of cultural safety into requirements for registration and accreditation, and the involvement of APRA after it was constituted as an institution. Yeah, so that's more frameworks as well, developing the notion of cultural safety within those frameworks. We'll see some more from some of those frameworks as we go on these slides. But this is a great little timeline that was in a recent paper on this topic. So then, how does cultural safety work with other related concepts? Yeah, it's kind of the antithesis of racism, discrimination, prejudice. So on this continuum, you go from the left to the right. Discriminatory environments about them, say those Aboriginal people, say, and you can move along a continuum. It's useful to think of it this way, to start with at least, from discrimination, prejudice, indifference, cultural awareness, cultural sensitivity, more about them and us, cultural responsiveness, cultural appropriateness. You know, the difference between some of these things is a little vague at times. Cultural competence, and then what they call here congruence or integration, which you could also say, talk about as cultural safety. And it gets increasingly moves from them to us. So this is where the self-reflection, awareness, accountability of organizational and individual interpersonal biases come in. That reflection becomes more apparent. Another way to think about it is that there's nested circles of these concepts. So you need to have cultural awareness to have cultural competency, but it's not all of cultural competency. And you need to have cultural awareness and cultural competency to have cultural safety, but it's not all of cultural safety. So some of the concepts require the others, but necessary, but not sufficient to achieve them. So nested, yeah. Then there's another continuum, cultural awareness, then cultural sensitivity, then cultural competency, then cultural safety. This probably makes the most sense these days if you want to draw a line between those. Once again, these could all be nested within each other in concentric circles. And then we have other models, Julie Coffin's model, cultural security, the different term. We also have in this cultural safety, cultural awareness, and so forth. So yeah, there's quite a lot of terms about, some reviews even of the variety of terms, and they often mean fairly similar things with some key differences between them. Here we have another busy diagram with some more thoughts on cultural safety. What does it mean? It's about patience. This is more your Venn diagram effect than your nested effect. It's about healthcare providers, things like translation services, cultural support, Indigenous autonomy over healthcare or self-determination. Specific things, but also general things. So self-determination is quite general. Recruiting Indigenous personnel in diverse roles is quite specific. Post-colonial theory is quite general. Training, knowledge sharing, coordinated discharge and referral, quite specific. So there's a mix in this diagram of quite different levels of focus in relation to cultural safety. Indigenous knowledge holders is a very interesting aspect, and we'll talk a little more about that to consider where the Indigenous knowledges come in to cultural safety. So this is probably still my favourite diagrammatic representation of cultural safety from the Aboriginal and Torres Strait Islander Health Curriculum Framework, 2014, very important document. And it encapsulates quite a lot of important aspects of cultural safety, I think. Relationships, partnerships, respect, communication, safety and quality, reflection and advocacy. Advocacy is not that commonly included under cultural safety, but I think it is important. So then we could look at the effectiveness of cultural safety. In other words, what studies have been done on how well it works to improve healthcare outcomes. We find a reasonably sparse literature, really, considering how important the concept is. Not a lot of empirical study has been done on this question of effectiveness, but there's some. So improvements in communication and interaction, respect, improvements in team functioning, clarity of roles, increased participation in decision making of patients and also healthcare providers, teams, Improvements in cultural knowledge, confidence, and competency to apply skills in diverse cultural contexts. Reduced risk of stress, anxiety, substance abuse and suicide attempts among patients. Improve recovery rates from mental health and cardiac surgery. Social support, healthy diet and exercise, and reduce readmission rates and reduce mortality. So some pretty good outcomes to show the effectiveness of cultural safety, but like I said, not a huge amount. A lot more commentaries on cultural safety and the need for it than there are on empirical studies of its effectiveness. So some questions to start the decolonising part of this decolonising cultural safety presentation. Is cultural safety for everyone? So traditionally, of course, cultural safety is very much about Indigenous peoples in Aotearoa, Australia, Canada, so forth. But there's also other minoritized groups who have poor health or health disparities. So what about them? And in some cases, developments in Indigenous health tend to migrate or translate to broader healthcare context because they represent best practice. So ethical frameworks would be a good example of that. So maybe this is another example where broadening is required to other groups. It's an open question. Is cultural safety just good caring talk to reconfigure experiences and relationships between Indigenous clients and the healthcare system? Asked in this particular quite good study on this topic. Good caring talk. Is cultural safety just another algorithmic band-aid for truncated modern humans who can't simply relate well to one another? You may have noticed some problems in the world with humans getting on well with each other. I certainly hope you've noticed because it's a big problem. Is cultural safety just common sense for the reflexive, or the wise, those amongst us who are wise? Not many of those left. Is cultural safety just avoiding dismissive medicine and refraining from medical gaslighting? Interesting new research on these topics. Well worth a read of that brief article. So where does it sit, I guess? Avoidance of things, specific efforts towards other things. What is cultural safety really, beyond definitions? Well, of course, it might be useful to talk about the two aspects of this term. There's culture and there's safety. What is culture? Would be the first question. And I wouldn't try defining that. People have tried and it's painful for them, the efforts involved. There's a number of what you could call inherently vague concepts in all human cultures, such as freedom, perfection, violence, etc. There's really no good definition for these things. Culture is one of those. It's probably because these things are so fundamental to society, to culture, that ineffable aspects of human experience. So they're axiomatic, they're premises of reality, so you can't define them very well. But nonetheless, we do have a general sense of what culture is, and it's a big topic. And it's the first part of the term cultural safety. What is safety, of course, would be the next question. But that is also, again, a tricky one to define. So let's ask the question, does cultural safety need to be underpinned by Indigenous culture? I think there's another slide about safety anyway, just FYI. But does it need to be underpinned by Indigenous culture and knowledge to create a racism-free environment? To demonstrate quality service to Indigenous people by providing that service within Indigenous cultural values and norms? To what extent are Indigenous knowledges intrinsic to cultural safety? In other words, can you achieve cultural safety in a Eurocentric colonial healthcare system? Or does it have to be indigenized? And then in that sense, if we broaden out cultural safety to all minoritized groups, how do we incorporate culture of each individual patient? Is this an unreasonable requirement for health practitioners individually or for health organizations to be, I don't know, including all cultures specifically in relation to each patient? These questions have been asked before, at least the last one, and they usually are not well answered, I would say. So cultural safety, back to the safety stuff. What is the interplay between cultural safety and safety in general? Can one be safe, but not culturally safe? So maybe physically safe, maybe emotionally safe, maybe spiritually safe, but not overall, not culturally safe. Can one be culturally safe, but not generally safe? Do we actually live in a cult of safety and security where protection produces pugnacious petulance among populations? Are we over-safetied in our society? Safety means whole or well kept, but can we be whole if we are kept well instead of learning to navigate risk, harm, or danger well ourselves? Security means freedom from care, but isn't caring and compassion what we need a lot more of in our society? So safety, question mark, is what this slide is about. And then we can start looking at some of the more recent interventions in cultural safety literature. This one from Canada, which really centers the notion of shared humanity and inclusive compassion as more central than, as you can see, than cultural safety, anti-racism, anti-oppression, social justice. So instead of being anti-something or particularly interested in cultural safety of a particular group, what about if everyone was really good at inclusive compassion and being human? Wouldn't that be great? Maybe we'd get somewhere then. So on that note, towards a shared humanity, here's a quote from a recent paper on cultural safety. When I can be my whole authentic self, I feel safe and know that I belong. When I can be my whole authentic self, I feel safe and know that I belong. So for patients in the healthcare system to be their whole authentic selves, what we actually need is healthcare workers, personnel, to have an opportunity to be their whole authentic selves. This means embracing vulnerability, self-disclosure, and decolonial relational autonomy and iridescence of individuality beyond only professional roles, and a cultural environment or an institutional environment where orders, shoulds, and oughts are outside our grammar of action. These are very primal ways of being, Indigenous ways of being. To put it more simply, how are institutions truncating those who work there? And how are those who work there then passing on that truncation to the patients who are being served by that system? I'd say that's a pretty big factor in what's going on in stopping us from inhabiting our shared humanity. So that brings us to epistemic vulnerability. How can we be genuinely open to learning, to being wrong, to making mistakes, to being uncomfortable, to getting beyond facts, and to being inviting change in ourselves? These are what some would call epistemic or ways of knowing vulnerability. And then there's principles to incorporate in practice in healthcare institutions that may really help with fostering cultural safety. The first one, of course, is nothing about us without us. And then these other principles: create circles, not lines, create less hierarchy, more inclusion, dialogue and empowerment. Be humble learners who practice deep listening, Indigenous skill, of course. Plan with, design with. So deep listening involves that epistemic vulnerability, not having predetermined answers to everything, and being good at taking criticism. Planning with, designing with is really about being co-liberators, conveners, collaborators, connectors, not representatives of others. Moving at the speed of trust is probably the simplest and hardest to achieve. Centering lived experience of, say, patients, Aboriginal healthcare workers and so forth, and seeking people at the margins to understand what falls outside the accepted knowledge and practices of Eurocentric colonial healthcare systems. So what would happen beyond hierarchy? What would your relationships look like if they were free of comparison, competition, or power struggles? How would your work feel if it were rooted in collaboration, kindness, compassion, and mutual respect, rather than status or ambition? What choices would you make if you trusted your intrinsic worth and the intrinsic worth of others? What would institutions look like if they were much less hierarchical? Would they even be institutions anymore? So thinking is not enough. We can convince ourselves of anything if we cut ourselves off from the wisdom, knowing, and empathy of our bodily feelings, intuitions, and sensations. In constantly reinscribing beings and things as bounded, knowable, and predictable, we engage in one of the most insidious forms of violence within modernity, that of fixing, forcing, and yoking the inherent vastness and radical incoherence of life to fit our meagre, insipid, and parochial expectations. And that's what the assumptions, prejudices, stereotypes, and so forth of racism in healthcare context is a example of. Fixing, forcing, and yoking vastness. What if we take up an invitation to leave the age of mastery, arbitration, and progress, and to surrender our need to be certain, right, good, and worthy? Rather than focusing on achieving results, outcomes, missions, targets, goals, objectives, deliverables, etc. What if we were beckoned not to save, fix, or even change life, but to continuously kindle kinship with the cosmos, within a politics where the ends never justify the means, but the means are the ends? In other words, what if we take the relationships, the partnerships aspect of cultural safety a lot more seriously? The kinship aspects. Some advice from my friend and colleague Tyson, recovering from modernity, I call it. And he says, what if we come to the realization that knowledge and spirit of country can restore us to sanity and make a decision to turn our lives over to the custodianship of country? What if we made a searching and fearless moral inventory of ourselves and admit to the ancestors, to ourselves, and to another or other humans or non-humans our wrongs? Through conscious relating, sounds a bit like critical consciousness from cultural safety, humbly and repeatedly ask ancestors, country and spirit, only for healing and knowledge of the pattern of creation and how to increase relatedness within it. So humility is often mentioned as well as an important aspect of cultural safety, and we see it here from Tyson's quote. So 2 more slides and then we'll talk. This is an invitation to societies that value self-realization, needs, freedom, interdependence, care, love, connection, celebration, beauty, grief, passion and cooperation without institutionalized exploitive hierarchies hoarding resources produced by the labor of others? Can we weave tapestries of empowered local cooperative communities grounded in anarchist politics, degrowth, wilding, unschooling, permaculture, decolonisation, myth, ritual and ceremony that inspire authentic, creative, thriving, playful, vivid, plural, messy, mystical, magical, vulnerable, sacred, sensuous, joyful, senseful lives? The challenge of life and cultural safety is to scrutinise appetites, thoughts, feelings, emotions, moods, desires, sensations, yearnings, longings, yieldings, repulsions, callings, instincts, hunches, inklings, and needs. What if we offered ourselves in full to the world as it is, without demanding acceptance, without demanding change, but welcoming it nonetheless? When it happens, transformation, metamorphosis, catharsis, intensity, and rupture, while attending to our limits within any given time and place. Could we meet others with curiosity, courage, vulnerability, love, honesty, and humility? Sense visceral needs behind actions, learn and grow with gratitude, connection and conflict, conviviality, but with less correction, contraction, contest. Attend to beauty, wonder, and grace, especially in dire and deeply violated situations, of which there are many in modernity. Pretty sure this is the last slide. It's simple but hard. Slow, pause, rest, sleep, idle, lull, shed, catalyze, channel, doula, delve, guide, receive the unknowable, unexpected, uncomfortable, uncertain, unthinkable, and imperceptible. Act with emotional stability, relational maturity, intellectual discernment, and intergenerational responsibility, beyond consumption, comfort, convenience, choice, and complaint. Metabolize, integrate agendas, assumptions, aversions, addictions, vices, disguises, demonizations, habits, triggers, complicities, projections, urges, traumas, and idealizations. Discern, perceive, relate, communicate, become without judgment, comparison, justification, condemnation, even without narrative, meaning, interpretation, or intellectualization. Let's talk.
I just realised the audio was off, so you didn't hear the applause in the room there.
Usually they filter out applause as a sort of a biased sound. Yeah.
So we've got a big audience online, and we do have a big audience in the room as well. That felt like sort of a half hour of really nice meditative sort of therapy, which is a beautiful antidote, I think, to a lot of what we hear in politics and in general. I think I've got some pretty good sound bites to take home from that. Pugnacious petulance, truncated modern humans, I won't forget. I really liked the comment on the slide about nothing about us without us, talking about move at the speed of trust, which is something I think we do really poorly in healthcare systems because we're under such time pressure all the time, and it is a critical thing that undermines the ability to provide culturally safe care. I think the fact that you haven't got that time to, which I think comes back to your point about can we actually ever provide culturally safe care in Western medical frameworks, and I think that thing about working at the pace of emergency medicine and with limited staffing, bad staff to patient ratios really just undermines the ability to practice in that culturally safe way at that sort of pace that you're describing. Can I see if people online have got questions? I'll just see if I can make sure I can see who's got hands up. No, I don't know that I can. If anyone's got their hand up, just jump in because I can't see. And if anyone in the room wants to ask a question, I'll put the ceiling mics on and hopefully that'll work.
Anna, if there's silence, I've got a question or maybe an observation or not an observation, actually, it's a question.
Yeah, go for it, Vicky.
Hi, Ian. I'm Vicky Kerrigan. I'm now an honorary fellow at Menzies. Part of the Communicate study. We work a lot in that cultural safety space. I'm just looking at some of the notes that I wrote. What have I had? Oh, sorry. I'm so sorry. I was just keen to hear you ponder a little bit more. And I know I'm not a healthcare provider, I'm a communications researcher, and that's my interest, racism and communication. And so that's where the cultural safety fits in. We need to be our whole authentic selves is a phrase that you use. Being our whole authentic selves is a way of approaching cultural safety, but also, I suppose, decolonising our processes. And I'm just was keen to hear you ponder a little bit more how that might work in those Western medical spaces. Yeah.
Well, it probably will work quite badly, I'd say. Yeah. Just giving people the slides to download if they want to.
Thank you.
The online ones anyway. Yeah, well, institutions are naturally truncating, so they think that safety involves more and more layers of rules about how people should behave, and particular forms of professionalism that are problematic, but also really just environments where people don't treat each other well. And so I'm sort of surprised that more people haven't mentioned it, the obvious fact that if healthcare staff are not treated well by their organisation or by other healthcare staff in the hierarchy, then they're simply going to pass that down the line to patients, aren't they? And it's just obvious.
I think that does sometimes come up in our sort of cultural safety chat group and in conversations that because a lot of this stuff is just about, as you say, being human and being respectful and being nice. And if the healthcare system sort of damages the healthcare providers working in it, then yeah, absolutely, that just sort of goes on down the line. And therefore, I think there are definitely a lot of people really interested in making healthcare services better, healthier places to work and better, healthy places for patients to be. But
Yeah.
it just feels like an uphill battle sometimes.
Well, it's very hard because that's not what the institutions are designed to be. And so, yeah, like I said, I don't think it works very well. I think that achieving that, like achieving cultural safety in the current configurations of institutions, is not feasible. So, yeah.
Mm-hmm. Any other discussion points that people wanted to raise? I think you've sort of lulled us all into a nice, calm sense of, complacency or something.
Sharon Thompson here. I have a question if no one else does.
Go for it.
Hi, Yin. Nice to meet you. I've read so much of your work. It's nice to have a virtual face-to-face with you, and thank you for everything you've said today. I did join a little bit late, but hopefully I got the gist of things. So I think it was a wonderful presentation, and I welcome everything you encourage. Just a question for thought, though. Oh, sorry, I should introduce myself. So I work at Menzies in the education division, coordinating the postgraduate public health and health research program. And I've also been involved in research in remote communities in my time. So yeah, just a question to consider. So how do we put ourselves, so those of us who are attempting to have critical consciousness or may have some degree of critical consciousness, how do we put ourselves in this open and vulnerable space in healthcare, in research, in society more broadly, if there's the possibility that the critically unconscious can take advantage of us and can take their turn to control us?
Yes, well, they will, I'm sure. That's why if you practice anything, whether it's vulnerability or bow hunting, it's good to be careful because they're dangerous activities. So I would suggest practicing with hesitancy and in moderation, and learning loops, action research loops of what works and what doesn't work, with whom, in what context. Context sensitivity is very important part of primal perspectives. So practice with care would be my suggestion. Push the boundaries, but also have your own boundaries so that you're not in danger, emotional, spiritual, physical danger. There's a lot of people who would like to live in a different world, and being a midwife to that world is a risky business, but important work. So keep your heart open to some extent, but learn how to wear armor and when to.
Thank you. That's a great response. And I guess something I also find useful is the oh, sorry, have I got my mic on still? Yes, I do.
Yeah.
Is the importance of collaboration, that if you stand together with others who have a similar stance or position and share your context, that potentially there's the age-old safety in numbers.
Yes. Activism is not something you want to be doing by yourself.
Great. Thank you for that.
That's great. Bart.
Hi, Ian. Bart Curry here. Can you hear me, Ian?
Can you hear?
I can bear it. Yes.
So my question is, maybe Annie, you can pass it on. I'm just wondering, Ian, how much penetration is getting into the curricula of health professional training, nursing, medicine, allied health, and whether there's standards that are being set at a national level, and whether your opinion is that it needs to be more formalised or it's more experiential that is required, so people can learn from experience of others, or just being embedded in a way that they can learn themselves how to be more reflective about how they're going about things. So in other words, how that can all get into, absolutely penetrate into health education throughout all the different disciplines.
Yes, I could hear that question, but haven't heard your voice for a while. It's good to hear it. Look, there are standards, increasingly requirements for this topic to be covered in medicine and nursing, among others, and a lot of that work is being spearheaded through APRA, and that's all good. But as with all these things, what are what's the experience, the knowledge, the skills of those who are providing such instruction or education in this space? I don't know that it's really what we need. So yes, of course, experiential learning is very much the best way to learn, and I think that healthcare education really is centered around experiential learning in the end. So let's include cultural safety in that. But let's make sure that we've trained the trainers to have a clue about what it actually is.
I just would jump in there. Hi, I'm Kaylee Wild. Good to see you again, Yin. We are looking to do some of that work with CDU through the new NT Domestic Family Violence Research Network. Still early days, but we're just having those discussions. So I just wanted to flag that. And if you want to have any more further chats, we'd love to hear from you.
Tell us a little bit more about this work that you're doing.
So I've come back to Menzies after 10 years away, and have been obviously doing lots of research in the domestic family violence space in the NT, but also Timor-Leste, and had worked on curriculum a lot there. And just seeing, what are we doing at CDU was one of the things the network identified, particularly around that trauma-informed care. You can not do any harm in your practice as a fundamental, the standards that we need to, the baseline that we need to be working with. So it's just having those discussions around how we can address workforce needs through a dedicated course, but also then embed these issues and these units across anybody who's doing frontline work that may be coming into contact with people, either who experience violence or use violence particularly. But then, that goes, it spans the whole quality of care spectrum for everybody. So we're just talking to NT Gov to be able to get support to do some of that work and really drawing in the lived experience. What are the video-based resources that we can use to harness that? Upskill lecturers, yes, but also creating a safe space where it's not going to be taken in, there's lots of values and stuff that can creep in. So there's protection we need to work on. But it's early days and we just want to have more chats.
The creep of colonial ways of being, knowing, doing. Yeah. Well, let's talk more about that. Kaylee, good to see you.
Lovely. I'll be in contact.
That's great. Any other people wanting to jump in with comments there? I might just mention, so Yin, you mentioned that cultural safety is sort of judged by the receiver of care, if we're talking about cultural safety in healthcare, and listening to, lived experiences and patient experience is really critical, which is something we recognise in the Communicate Study Partnership. And so I just want to give a plug for the fact that we've got 3 new podcast episodes coming out for the Ask the Specialist podcast. So it's a series 2 focusing on end-of-life care. So all 3 episodes focus on basically palliative care. So Vicky Kerrigan's been really integrally involved in that, but with a new team from Central Australia, because if people are familiar with Ask the Specialist, it's a podcast drawing on the experience of specialists who are elders and community leaders who've had experience in the healthcare system, helping answer doctors' questions about how they want to receive healthcare. But anyway, we're excited that we'll have these 3 new episodes to launch in a few weeks' time.
Well, it's a great podcast series. Yes, I recommend people listen to that.
Thanks, that's great. Look, thank you so much again. You've really generated a lot of discussion and contemplation, I think, and thanks for your generosity in sharing the slides as well, because there's certainly quite a few concepts in there that I think will be really valuable for us. So maybe if we can just join again in giving Yin a big thank you for your time and your thoughts today. Right, I'll stop the recording. I want to